Hello, everyone. Welcome to this session on supporting policymaking in relation to the use of multiple micronutrient supplement and antenatal care program. My name is Gilles Bergeron. I am SVP for Nutrition at the New York Academy of Science, and we host the MMS, the Multiple Micronutrient Supplement Technical Advisory Group. And so we've been closely involved in the preparation of materials that will be presented today. The aim of this session is to explain the reasons to support a policy decision to implement multiple micronutrient supplement intervention for pregnant women in the context of national programs. So let me get started with some background. The importance of good maternal nutrition during pregnancy is well established. It affects It affects fetal development, survival at birth, and is a factor that influences growth from birth through childhood and beyond. Focusing on pregnancy in particular, inadequate maternal nutrition can result in low birth weight infants as caused by preterm birth, fetal malnutrition, or both. This is a critical problem for public health. In 2015, for instance, it was estimated that 14.6% of births globally, totaling 20.5 million births, were LBW, with the problem being most severe in South Asia and Sub-Saharan Africa. Babies born with low birth weight have elevated risk of death in infancy. They are more likely to suffer from stunting and impaired development in childhood, and to be affected by chronic diseases in adulthood. Concerned with this, WHO released an antenatal care guideline in 2016 that recommended the use of IFA ANC program. Since then, evidence showed this has showed some benefits, but in the years since, solid evidence has been put forward establishing that women who receive MMS in pregnancy can further reduce several types of risk when compared to IFA. The WHO revised its guidance in 2020 to acknowledge those benefits, but recommends that countries aiming to adopt MMS instead of IFA do so within certain parameters, which will be described in today's presentation. So the aim of the session today is to focus on the rationale for country decision makers to adopt MMS rather than IFA as standard of care in their ANC program. To lay that case, we'll first start with three presentations laying out the evidence base on MMS. Dr. Emily Smith will review the evolution of the MMS evidence base since WHO's 2016 guidance. Then Dr. Raina Engelstone will expose the economic rationale for choosing MMS over IFA. And Dr. Megan Bourassa will provide a framework for country decision makers around MMS policy decisions. Following those technical presentations, we will hear two speakers reporting on experience from countries that have adopted MMS or are in the process of doing so. Dr. Luyên Markleng will first describe Myanmar's experience in introducing MMS as a result of their data-driven policy. Dr. Nita Dalmia will follow with early lessons from the introduction of MMS in 4 countries of Asia and Sub-Saharan Africa. This will close our cycle of presentations. Then we'll move to the questions that we will all be posting as we go along. Some housekeeping notes before we get started. To submit your question, you please use the chat box, clarifying which presentation you're referring to, for instance, by naming the presenter. The more concise and more specific your question, the better it can be answered. Rather than combining multiple topics in one question, submit several posts so that we can better parse them and address them appropriately. Behind the scene, we'll be sorting the question, regrouping them in broad themes, and combining them, those of similar nature, to avoid repetition. So you may not see your question answered like word for word, or presented word for word, but it will be addressed in a general way. We have the benefit of having Dr. Parul Christian, one of the top specialists on MMS, to moderate the Q&A session. She will respond to your question or redirect to presenters as appropriate. Each presenter will briefly introduce the next speaker. Detailed biographies can be read directly online on the conference page under Connected People. With all that said, I now pass the screen to Dr. Emily Smith, a faculty member at Georgetown University and one of the most prolific writers on this subject. So Emily, screen is yours.
Great. Thank you so much, and good afternoon from rainy Washington, D.C. today. I want to start by telling you a little bit about the problem, which will help put the evidence in context. So WHO estimates that 5.4 million children died in 2017. And while the progress has been astounding, a 58% reduction in child mortality in the last 3 decades, our progress is not fast enough, as shown on the left. Compared to the average 2 to 4% annual reduction in child mortality in sub-Saharan Africa during the MDG era, that's the green area, substantial acceleration is needed to reach the 6 to 9% reductions needed to attain the SDG targets by 23. That's all that dark blue area on the second map. And furthermore, the causes and timing of child death are changing. So on the right, you see that neonatal mortality in orange accounts for an increasing proportion of all child deaths. In 2015, neonatal mortality increased to account for nearly 60% of all child deaths in South Asia. And half of that's due to prematurity, which you see in the light orange. And that's a big problem because we have so few tools in our toolbox to address that cause of death. We track low birth weight, which is a proxy for preterm birth. And as Jill mentioned, you see here that the prevalence of low birth weight, as estimated by Hannah Blencow and colleagues in 2015, we see this alarming finding out of the work that we're not making much progress in reducing low birth weight. From 2000 to 2015, the annual rate of reduction was just over 1.2%. We'll need to double that or even triple that in some areas to meet global goals by 2030. And so what can we do about this? How can we accelerate meeting global goals? Decades of research have shown that poor maternal nutrition, which you see indicators of on the top left in blue, is a major cause of babies being born too small or too soon. Furthermore, research shows that maternal malnutrition tends to travel together. You see in the bottom right data from Nepal showing that women tend to be deficient not in a single micronutrient, but rather multiple micronutrients. And that's how we got to more than 3 decades of research, plus a rigorous WHO guideline, which was recently updated in 2020, that provides one of the many solutions to accelerate progress in maternal child health and nutrition. Antenatal multiple micronutrient supplements, or MMS, which include iron and folic acid, are now recommended in the context of rigorous research. And the guidelines specifically note that when you're developing the new program of MMS, that implementation research is important to ensure acceptability and feasibility, equity, and cost effectiveness. And my colleagues will talk more about that later in this session. But what I want to do is be clear about the evidence. And to do that, let's be clear about what's in the IFA and the MMS. So here you see the MMS formulation, which was developed in the late 90s, contains 1 daily dose of 15 different vitamins and minerals, and that includes iron and folic acid. That dosage is based on the daily requirements for pregnancy. So I sometimes call this a comprehensive prenatal vitamin. There are 2 systematic reviews that we can look to for a summary of the evidence, and these are the reviews that informed the 2020 update to the WHO guidelines. So you see there's the Keats et al. Cochrane review, which includes data from 20 randomized trials in 16 low and middle income countries and include 141,000 women. We also have a project that I worked on with all of the investigators from the randomized trials that was published in 2017 that includes data from 14 of these countries, 17 of these trials, and 112,000 women. I work on a lot of systematic reviews, and this is a lot of evidence. This is a lot of gold standard randomized trial data informing us. So what do these reviews show? Overall, these reviews are consistent and find the same results. For example, that MMS, or the prenatal vitamin, the comprehensive prenatal vitamin, when compared to iron and folic acid alone, reduces the risk of low birth weight by 12 to 14%. We also show that MMS compared to iron and folic acid alone reduces the risk of being born small for gestational age, and it also reduces the risk of preterm birth by about 5 to 7%. Here you see some of the details from that consortium of international investigators that tried to answer the question, are there any groups of women who benefit more from MMS, or any groups of women that might be harmed from MMS? And this was an important question that had previously come up. There's a lot of data here. You don't need to read every single estimate here. But what you're looking at are each of those dots, each of those rows is a different meta-analysis in a different subgroup of women. Women who are underweight or overweight, women who are tall or short, women who are anemic, women pregnant with their first babies. What you're looking at here is relative risks, which are less than 1, are highlighted in green. And that indicates that MMS is beneficial or more beneficial than iron and folic acid alone for that subgroup of people. So here for low birth weight, you see that the benefits are apparent in all subgroups. The same is true for preterm birth. Again, all of these individual subgroup analyses looking within different groups of women, we see benefits for MMS in reducing preterm birth. And similar for SGA, although the effect is a bit small, it's consistent that there are benefits for nearly everyone in each of these subgroups. Now, when we look at this carefully, we can see that the larger gains are for undernourished women, but we see benefits for everyone. And most importantly, we don't find harmful effects for anyone. The trials overall also suggest that MMS compared to IFA leads to a small reduction in stillbirth. But you see on the right that overall the trials don't find a reduction in neonatal mortality for the general population, and several people have wondered how this can be given the improvements in low birth weight. And that's exactly one of the issues we sought to understand in that 2017 research. And here what you're looking at are subgroups which help us understand who benefits. And here you see clearly that consistently MMS reduces the risk of death for female infants. Now, we don't know why this is for sure. I suspect it has something to do with the different causes and timing of death for male and female babies, but there is limited data on this globally. But it's well established in the adult literature that men and women benefit differently from preventive therapies and die from different causes. So we see that MMS improves birth outcomes, but what about side effects? My obstetrician friends anecdotally will always tell me that IFA or supplements in general cause their pregnant patients' stomach problems. But here I'm showing you reviews from randomized trials of both IFA and MMS. IFA on the left, MMS on the right. And what we see in all of the trials, although there's somewhat more limited research on side effects, but we see in general that yes, pregnant women do have stomach problems from constipation to heartburn to nausea. But when we look in these randomized trials, we don't find evidence that MMS or IFA increases the risk of side effects. Finally, another key piece of evidence that's been published by Alison Jernand at Penn State last year. Here she summarized the potential risk of exceeding the upper limits for micronutrient in pregnant women in the case that, say, they're taking a multiple micronutrient supplement and taking a high quality diet themselves. So when we assume the best case scenario, this high intake plus the standard MMS, only niacin and iron are close or would slightly exceed the upper limit in this hypothetical situation. And while overall there's a bit limited information on pregnancy-specific risks from excess intake, we do know for each of these two nutrients, for niacin, iron, that any intake at this level, any side effects might be transient or mild. And so in sum, the evidence is quite clear. Like I said, I look at meta-analyses often, and this one is quite clear that high-quality randomized trials show that MMS compared to iron and folic acid alone reduces the risk of low birth weight by 12 to 14%, and also reduces the risk of being born preterm or small for gestational age, and reduces the risk of mortality among female infants. And importantly, all women and children were found to benefit, although the data does suggest MMS is even more helpful in undernourished women. And with that, I'll look forward to future discussion here or online. And next, I will turn it over to Dr. Raina Engel-Stone, an assistant professor in the Department of Nutrition at the University of California, Davis. Her research is on global public health nutrition, and here she'll tell us specifically about her work and others around the economic rationale for MMS. Over to you, Raina.
Okay, thank you so much, Emily, and thank you to the organizers for the chance to speak today. I'll start with a disclaimer that my training is in nutrition and not economics, but I will speak to work that is done by these two groups working together. So as Emily explained very nicely, the benefits of MMS compared to IFA in pregnancy for improving birth outcomes are very clear. But the decision to make this programmatic transition requires other considerations, and one of these is, of course, the cost. So the questions that I will address here today are, will the distribution of MMS be more cost-effective than IFA tablets? And then how does this compare with other potential investments in maternal and child health, given that budgets are always limited? So what is the cost of MMS tablets? There's no single answer to this question. These costs may change over time depending on ingredient costs and demand, and they may also be affected by the scale of production and the location of that production. In some cases, currently costs as low as those for IFA have been negotiated for MMS so that the price is the same. But because MMS contains more ingredients, it's also reasonable to expect that it will be more expensive in some cases. And there are also the programmatic costs of actually making that transition to consider. So if the tablets are more expensive, then is this a cost-effective investment? Over the past several years, there have been a few analyses that have addressed the cost-effectiveness of MMS relative to IFA tablets. And these are shown here. The first was focused on the MiniMat trial in Bangladesh. The second was a modeling analysis for 3 countries that used the overall effects from 2 different meta-analyses to look at the relative benefits of MMS compared to IFA. And I've noted on the side here that the underlying model for this analysis is also part of the MMS cost benefit tool by NI, which is available online. And so users can generate results for a number of other countries using that tool. And those were also used to examine some other scenarios looking at different formulations of MMS and IFA for WHO deliberations. So those results are also available. And then the third analysis is one that our group did. This is with Steve Fosti, Shika Kumorji, and Laura Meisendick. And we conducted this analysis for Bangladesh and Burkina Faso. And this differed somewhat from the prior analysis in that we included both the overall effects as well as the subgroup effects from the IPD meta-analysis that was just presented. So we included the potential for different effects on subgroups of the population. So the point here is that although these analyses use different methods and different input data, in some cases, the results are remarkably similar and indicated that the switch from IFA to MMS could cost somewhere between $3 to $47 per disability adjusted life year or DALY averted, or up to 113 in the case of some of the WHO analyses. And these values would all be considered very cost effective according to the WHO threshold of cost per daily averted below per capita income. So these modeling results are very favorable for MMS. There are also some factors that aren't accounted for yet in some of these analyses, including the potential for a gradual transition of IFA to MMS. For example, if a country rolled out this transition in stages. And importantly, the analyses mostly assume that exactly 180 tablets are distributed and consumed for each covered pregnancy. And we know that in IFA programs, adherence is often a challenge. And in reality, the tablet costs will depend on the systems through which those tablets are purchased and distributed. So we have conducted some additional simulations to address some of these programmatic issues as well. These were done again in the context of Bangladesh and Burkina Faso. And this shows you the structure of the model. And I'll just say very briefly that the three white boxes on the side here show the main inputs into this model. So we're using population structure data from the LiveSave tool for an 11-year projection scenario. Effect sizes, again, from the IPD meta-analysis for overall effects, and then accounting for potential effects among different subgroups. So for example, women who are anemic versus non-anemic. And then other data and assumptions that go into the model, including IFA coverage and adherence. And that's used to estimate the number of different natural outcomes averted, for example, cases of preterm birth averted, which is then used to calculate DALYs and then combined with the cost to calculate cost effectiveness. And we've examined 4 different scenarios. The first we're calling the immediate shift scenario, which is analogous to the results that have been published already. So this is assuming that MMS immediately replaces IFA in the first year and that 180 tablets are consumed by each pregnant woman. The second scenario introduces a gradual transition. So assuming that that replacement happens over 3 years gradually and including some fixed startup costs for things like stakeholder consultations and trainings. And then in the last 2 scenarios, we're introducing different scenarios for exploring how many tablets might be purchased and consumed. And in the case of Burkina Faso, the assumptions are based on DHS data on reported tablet use. And in Bangladesh, in the absence of that data, then the number of antenatal care visits is used as a proxy for tablet receipt. So the results are shown here. These are expressed as cost per disability adjusted life year, year of life lost, or years lived with disability averted by this transition. So I'll focus on within these red boxes here. These are the results for cost per total DALYs averted in different scenarios. So considering low birth weight or preterm birth, and with and without accounting for effect modification, so subgroup effects. So if you look at the blue dots on the left, that's the immediate shift 180 tablet scenario with cost per DALY averted less than $15, which is quite low. And then you see that as we add the transition and account for different tablet distribution scenarios, the dots shift to the right, so that in the most conservative scenario in the green dots, we now have up to $30 per DALY averted in Bangladesh and just over $100 in Burkina Faso. So what this suggests is that issues related to program management as well as adherence will have implications for cost effectiveness. And this thus represents an opportunity to use the strengthening of these distribution programs to increase both the impacts and the cost effectiveness of these supplements. And so lastly, to put these in context of other interventions that are in place, I've overlaid these results against this very nice figure from a chapter by Sue Horton and Carol Levin, which shows the cost per DALY averted from different reproductive, maternal, and child health interventions. So this is a log scale. So this is ranging from less than $10 per DALY averted all the way up to several $1,000s per DALY averted. So you can see that with our analyses for the immediate shift, as well as that by Kashi and colleagues, that $42 per DALY averted is quite cost effective in relation to some of these other options. And even when we're accounting for this gradual transition and different tablet distribution scenarios, the cost per daily averted remains quite favorable in relation to other interventions to prevent disability. And I'm not showing cost per death averted, but the picture is very similar. So to summarize, the evidence suggests that MMS is very cost effective, according to the WHO definition, for reducing mortality and disability adjusted life years compared to IFA, even when we're accounting for some of these programmatic issues that arise, like how the cost of the transition and varying number of tablets. So we've estimated the cost per daily averted and as well as the cost per life saved. And as have other investigators now, and these compare very favorably with other interventions to reduce morbidity and mortality. So the final point that I want to make is that strengthening program implementation then is a way to increase both the impacts and the cost effectiveness of this transition. It's possible that offering a new product may be an opportunity to increase demand, and the implementation research that is necessary to do this is consistent with the updated WHO recommendation to deliver MMS in the context of research. So with that, I'll end by thanking my co-authors at UC Davis and many others who have supported this work. And I'll turn things over to the next speaker. So Dr. Megan Bourassa is the director for the Nutrition Science program at the New York Academy of Sciences. And she will present the work from the MMS Technical Advisory Group on a framework for decision makers on MMS policy decisions. Over to you, Megan.
Great, thank you so much, Raina. So we started planning this session about a year ago, and this was my original title. Of course, a lot has changed in the last year, including new guidance from WHO. So I'm going to slightly update my title and the presenter list to include the interim country level decision-making guidance for introducing multiple micronutrient supplementation for pregnant women. And this is what I'll present today is from a document that has just been released. You can find it on our website at nias.org/MMS_guide. And this document was prepared by members of the Multiple Micronutrient Supplementation in Pregnancy Technical Advisory Group, including members from UNICEF, Micronutrient Forum, Nutrition International, and Vitamin Angels. And so this document seeks to contextualize the updated WHO guidance that was released a few months ago, as well as bring in some lessons learned from the countries that are already implementing MMS around the world. So because we've just heard a lot about the evidence and the cost effectiveness that MMS is significantly more beneficial than IFA and can be very cost effective, I thought I'd start with my take-home message from this document, which basically says that in settings where dietary quality is poor, micronutrient deficiencies are common, as well as anemia and low birth weight are significant public health problems. Daily MMS can improve the micronutrient intakes during pregnancy. It can also help prevent iron deficiency anemia and reduce adverse pregnancy outcomes, which include things like low birth weight, small for gestational age, stillbirth, and preterm birth. So to give a little bit of context to this, we all know that micronutrients are especially important during pregnancy, and they're necessary for positive pregnancy outcomes, and that many micronutrient requirements increase during pregnancy. So I'm showing here the recommended intakes for pregnant women, and this is on the far right column is the percent increase over non-pregnant and non-lactating women. And you can see for vitamins like niacin, vitamin B6, folate, as well as iron and iodine, these increase by up to 50%, which is quite a dramatic change. We also know that micronutrient deficiencies are relatively common in low and middle income countries. And so this chart shows the regional estimates of micronutrient deficiencies and anemia among women of reproductive age. So not just pregnant women, but all women of reproductive age. And we can see that the many micronutrients like vitamin D and iodine and zinc are relatively common deficiencies around the world, and especially in low and middle income countries. We also know from WHO's estimates that about 40% of all pregnant women are anemic, but we saw from Emily's data that she presented that MMS had a greater effect on multiple birth outcomes among anemic women. And we also know from the data that MMS with 30 milligrams of iron has a similar impact on maternal anemia as 60 milligrams in iron and folic acid supplements. So also in 1999, Emily mentioned this, the United Nations International Multiple Micronutrient Antenatal Preparation, we call it UNIMAP, was created. And this was designed to help pregnant women meet these micronutrient requirements and was designed to give one recommended daily allowance of most of the 15 micronutrients that it contains. And this is really to help bridge that gap of micronutrient deficiencies that we know are relatively common. And it was also the most commonly used formulation in the clinical trials that have built the evidence base. And one of the important things that I want to point out from the deliberations of the group that designed this formulation is they settled on 30 milligrams of iron because the presence of other vitamins like A and C, as well as riboflavin, can help increase the absorption of iron. So now I'll turn to the updated guidance that was released just a couple of months ago. And it's now recommended under a context-specific recommendation for research that MMS be used. And there are two main areas where WHO has made this recommendation for research. The first is around clinical research, and this is to help better establish the gestational age using early pregnancy ultrasounds. Many of the effects that we see are around small for gestational age or preterm birth that rely on an accurate estimate of this gestational age. And they also were interested to see some of the longer term follow-up of infants, which we know is going on in a few of the trials that are continuing today to follow up on the infants that participated. And the MMS tag will also be developing a global research agenda on MMS to hopefully help guide the future research efforts on this front. The other component of research recommended by WHO is that in places where they are considering implementing MMS, to do this in the context of implementation research, which is really good advice for any new program to start by doing some implementation research. And this is really to help understand and address the barriers to effective implementation. And this will help optimize the impact of switching to MMS. As we heard in the previous presentation from Reina, this is a really good opportunity to maximize that cost effectiveness if you can improve coverage or adherence. And so implementation research should really be considered as part of any new program for MMS. So the next couple of slides, I want to go over some of the lessons learned from a few of the countries that have already been implementing MMS and some guidance for countries who are interested in introducing this within their programs. And so these are kind of useful advice and guidance to make sure the program is successful as possible. So the first is to create an enabling environment to support implementation research. This includes advocating for the use of MMS and making sure everyone understands the importance of using it and creating this MMS policies that everyone is supportive of. The other thing to consider is to look at the key determinants of anemia. We know that not all cases of anemia are from iron deficiency. So if there's a high prevalence of malaria or soil-transmitted helminthic infections, these are really important to address because adding additional iron isn't necessarily going to solve the problem and could contribute to maternal anemia as well. So it's also important to introduce MMS as part of a comprehensive antenatal care package because this will make sure that women are getting good quality care as well as guidance around how to take MMS and good nutrition during pregnancy. And we also want to encourage countries to look at their supply chain to ensure uninterrupted and good quality MMS supplies. If there are any issues within the supply chain, this may create stockouts and might prevent the availability of MMS at an antenatal care clinic, which may hinder the coverage. A few other important programmatic considerations for MMS are to retrain or train the health workers to be able to have the capacity and ability to deliver effective messaging to pregnant women. So this can include helping them develop strategies to remember to take the supplements every day, or how to combat any side effects that they may experience from the MMS. And then also to make sure that this messaging is received by the pregnant women and adolescent girls, as well as any key influencers within the community. So this can create a very supportive environment for women to be taking MMS during pregnancy. And it can also encourage eating a nutritious diet. Next, also in line with WHO guidelines, it's really important to be monitoring pregnant women for anemia. Neither IFA nor MMS contain a recommended amount for treatment of iron deficiency anemia, but WHO recommends monitoring this at least 3 times during those antenatal care visits during pregnancy to make sure that anemia can be treated during pregnancy. And it's also very important to integrate MMS into routine monitoring as an iron-containing supplement. This will help keep track of where it's going and how much is being used, and you can use this as sort of a feedback loop to continuously improve the programs. So I also want to acknowledge the context of COVID-19. We know that this has had a pretty dramatic impact on the quality of diets and access to antenatal care services. And this has made it even harder to achieve an adequate diet during pregnancy. However, we know that MMS can be a part of this pandemic response to improve the nutrient intakes of pregnant women. And it's been recommended by a consortium including UNICEF, the World Food Program, the Global Nutrition Cluster, and the Nutrition GTAM to use MMS to ensure adequate micronutrient intake where nutritional deficiencies are high and where food distribution may be disrupted. So this is another potential use for MMS during the pandemic. So in conclusion, I'll leave off roughly where I started, just to summarize. In settings where diets might be of poor quality and micronutrients are common, we know that MMS can help overcome some of these challenges and reduce the adverse birth outcomes that are relatively common in some areas, including low birth weight, small for gestational age, stillbirth, and preterm birth. We also know that this is a very safe and cost-effective intervention, and it can help accelerate progress towards the Sustainable Development Goals. We heard from Emily's presentation that we are not anywhere near reaching the low birth weight reduction goals of WHO, but this is certainly one of those interventions that can help with that. Again, if you'd like to see the guidance, you can follow the website there. You can also get additional information on our website, which is nias.org/MMS. And this is a way to keep tabs on all things that the MMS Technical Advisory Group is doing. And thank you all for your attention. And I'd now like to introduce Dr. Nguyen Mar Lang, who is the Acting Director of the National Nutrition Center at the Ministry of Health and Sports in Myanmar. And she'll be giving us an update on what they have been doing there to introduce MMS policies.
Thank you, Megan, for the introduction. Good day, everyone, and thanks to the organizers for allowing me to make the presentation in this section. I'll be sharing with you about the introduction of multiple micronutrient supplementation in Myanmar. The presentation will cover anemia situation in the country, iron deficiency anemia control program, how we shifted from IFA to MMS, what are the challenges, opportunities, and program decision and way forward. This slide shows you the anemia situation in Myanmar last 20 years back. As you can see here, 3 in 4 children under 5 years of age and pregnant women, nearly half of the non-pregnant women and 1 in 4 adolescent girls had anemia in pregnancy. Out of 4 geographic zones in Myanmar, the rate of anemia was highly prevalent in Delta and coastal region. So we started iron deficiency anemia control program in the country with 3 main strategies, including iron folate acid supplementation, nutrition education, and integrated deworming. For IFA supplementation, UNICEF provided us technical and financial support for IFA tablets containing 60 milligram ferrous sulfate and 400 microgram folate acid. We provided the IFA tablets to pregnant women and adolescent schoolgirls. In addition, we also provide iron syrup to the children between 6 to 35 months of age, started in 2001, but the program was stopped in 2008 because of the poor compliance of the syrup by the children. Then we tried to introduce the home fortification with micronutrient sprinkle starting from 2012 in some selected areas of the country. So regarding the IFA supplementation for the pregnant women, we started the program in 1980 in selected areas, and we expand the program as universal supplementation for all pregnant women who are taking antenatal care services in public health facility. The program became universal since 1990. We provide 1 tablet of IFA to every pregnant woman starting from first antenatal visit. So we provide a total of 180 tablets to each pregnant woman. According to Myanmar Demographic and Health Survey 2016, 87% of the pregnant women in Myanmar receive IFA supplement, but we don't have the data on adherence of the supplement. For the adolescent girls, we provide biweekly IFA supplementation during the academic year for the girls who are attending in middle and high school, and the program was expanded as universal since the academic year 2017 and 18. Together with IFA supplementation, we also provide nutrition education through IEC material, face-to-face communication and counseling, and also providing the messages in the social media. Considering one of the causes of anemia is the worm infestation, we also implemented the integrated deworming program starting from 2005 for the children between 2 to 9 years of age. Usually we provide albendazole 400 milligram biannually in February and August, but starting from academic year 2017 and 18, we expanded the deworming program to all students in the country who are attending primary, middle, and high school. For the pregnant women, we provide mebendazole 500 milligram single dose after the first trimester of pregnancy. So by providing that IFA supplementation, nutrition education, and deworming, how was the anemia situation in pregnancy is declining. Here you can see that the prevalence of anemia was 71% in 2003 and declined to 57% in 2016. But it is quite apparent that the problem still existing as much above the severe public health significance level. One of the global nutrition targets set by 2012 World Health Assembly is the reduction of anemia in women of reproductive age. So following that recommendation for the pregnant women, our target for reduction of anemia in pregnancy will be 35.5% in the year 2025. As mentioned in the previous previous speakers, that one of the consequences of anemia in pregnancy is the low birth weight. So how is the situation in Myanmar? Here you can see that the reduction of low birth weight within 16 years period was not quite satisfactory. Very slow rate of reduction in low birth weight, and we can, according to the global nutrition target, our target for low birth weight reduction will be 6.02% to be achieved by 2025. So as I already mentioned, that although the prevalence of anemia in pregnancy has been declined, but the problem still existing as severe public health significance. And as we all clearly know that there are several adverse consequences of anemia in pregnancy and adverse consequences of multiple micronutrient deficiencies, including increased maternal morbidity and mortality, perinatal mortality, increased risks of low birth weight, small for gestational age, and impaired cognitive and physical development and poor micronutrient status in the baby. Given the fact that we have estimation that half of the anemia are usually due to iron deficiency, but we need to consider there might be the potential of coexistence of other micronutrient deficiencies, especially in those pregnant women who have increased requirement of multiple essential micronutrients as presented by the previous speakers. At the same time, although we don't have clear evidence by the time for outweigh of benefit by replacing the IFA with MMS, but we need to consider there might be potential benefits of replacing IFA with MMS. So National Nutrition Center decided to introduce MMS in pregnancies in the year 2016, considering those possible coexistence of multiple micronutrient deficiency in the pregnant women and also the benefits of MMS over IFA. UNICEF fully supported us with this initial transition of providing MMS in pregnancy by providing the MMS supplement using the UNIMAP formula. And starting from 2017 and 18, Ministry of Health and Sports handed over the procurement of MMS supply using the ministry budget and the domestic production. When we implement that shift from IFA to MMS, there was some critics that on that change, pointing out that the WHO 2016 recommendation, multiple micronutrient supplement is not recommended for pregnant women to improve the maternal and perinatal outcomes. But we keep our rationale to change from IFA to MMS, because even in that 2016 recommendation, it is clearly mentioned that the policymakers in the population with high risks of nutritional deficiency should consider the outweigh of benefits to provide the MMS supplement which contain iron and folic acid. And we also consider there might be potential benefits of MMS over the IFA. So we continue with MMS supplementation in pregnancy. Of course, we encounter challenges and we also have some limitations, including shortfalls in the supplies due to limited government budget. In the initial year, we don't receive the adequate amount of supply that we have requested from the ministry. And during the initial stage, as I already mentioned, that we ordered the production from the domestic supplier, but since they don't have such experience before for the huge amount of production, so the supplier could not fulfill the demand that we have requested. Another challenge is that in the subsequent years that there is some use of different MMS specification by the suppliers. And as I already mentioned, that we don't have the data on adherence or compliance of the MMS. So far, we can only provide the MMS to the pregnant women, but we still cannot cover up to the lactation period. Despite those challenges, we also have some emerging opportunities, as clearly highlighted in the first speaker, Emily, that MMS have clearly shown the evidence of outreach of part outcomes like reduction the rates of low birth weight, preterm baby, and small for gestational age. And in last year back in New York, there was the launch of the event Healthy Mother, Healthy Baby Accelerators, where our Union Minister for Health and Sports has also attended. In that event, the expert groups has discussed about the introduction of MMS in the pregnancy, and we found that the report of that movement showing that MMS for pregnant women significantly decreased the risks of low birth weight and very low birth weight baby. And MMS is particularly important in low and middle income countries like us, because the diets rich in micronutrients are often unavailable or unaffordable for the women of reproductive age. So those facts and findings, as clearly highlighted in the initial speakers, are really supporting as our initiative to move from IFA to MMS during pregnancy. At the same time, we also received the strong commitment and support from the ministry to proceed with MMS in the pregnancy. And our Union Minister had communication with CAC Humanitarian Foundation. And finally, we could sign the MOU between ministry and CAC Humanitarian for donation of MMS to Myanmar for the 5 years period starting from 2019 until 2023. And as mentioned in the previous speakers, WHO updated recommendation was also released in 2020 for antenatal MMS supplement, including iron folate, are recommended in the context of rigorous research. So in Myanmar, we also try to find out the evidence-based decision-making process. So we have conducted the first ever comprehensive Myanmar micronutrient and food consumption survey between 2017 and 18. Let me share with you some of the findings from that survey. In this figure, you can see that the anemia among different target groups, and you may see that about 1/3 of preschool children, adolescent girls, lactating mothers, women of reproductive age had anemia, while 1 in 2 school-aged children and 2 in 5 pregnant women had anemia. So what about the anemia progress in pregnancy again? Here you can see that the prevalence of anemia within 15 years period have significant reduction in the prevalence of anemia. However, it is still important to note that the prevalence of anemia in pregnancy still remain in the country as the public health significance. In addition to that, we also assess the other micronutrient status of pregnancy in that survey, and let me start with iodine status. So the median urinary iodine concentration in pregnant women at the union level is 122 microgram per liter, and when we analyze the subnational level analysis, we also found that most of the states or regions inside the country, the pregnant women median urinary iodine concentration are below the reference value of adequate iodine intake, which is 150 microgram per liter. We also found that the coexistence of multiple micronutrient deficiencies in pregnant women in the country, with 28% prevalence of iron deficiency, 61% of vitamin A D deficiency, 71% of thiamine deficiency, while only less than 1% had vitamin A deficiency. So all those findings are clearly highlighting us that we need to proceed with our initiative to shift from IFA to MMS for the better maternal and birth outcomes as mentioned by the previous speakers. So using those findings from that micronutrient and food consumption survey, Ministry of Health and Sports, in coordination with all the concerned ministries, we have developed the multi-sectoral national plan of action on nutrition. We call it MSM-PAN, with the overall goal to reduce all forms of malnutrition in mothers, children, and adolescent girls. Among the expected outcomes to be achieved by each and every ministry, from the Ministry of Health and Sports, we aim to achieve the increased quality and utilization of nutrition-related services and optimal nutrition behavior among pregnant and lactating women, children, and adolescent girls. One of the key interventions under MSM-PAN is provision of multiple micronutrient supplementation in the pregnant women. So based on that, those data-driven program decision and policy-making process, our way forward is we will continue with the implementation of MSM-PAN intervention, including MMS in the pregnancy. In addition, we have just finalized the maternal, infant, and child nutrition implementation plan for the year 2021 to 2025, in which the key interventions for improving maternal nutrition include MMS supplementation, as well as the improving maternal dietary diversification. In addition, the ministry will build on the early success and lesson learned to ensure that all the pregnant women in the country can benefit from MMS program and achieve the positive pregnancy and birth outcomes as mentioned earlier in the previous speaker. And while CAC Humanitarian is provided the donation for MMS to contribute certain proportion of our pregnant women, Ministry of Health and Sports will also increase contribution from MMS procurement using the government budget. And we plan to explore the MMS adherence by conducting a collaborative study with Harvard University, in which we also consider to assess what are the challenges and barriers that the pregnant women encounter when taking the MMS. So with that, I'd like to end up my presentation, and thank you so much for your kind attention. These are the reference lists that I have used for my presentation. So now let me invite Ms. Nida Dalmier, who is the Global Lead for Maternal Nutrition, working in UNICEF headquarters. Nida, the screen is yours.
Great, thank you so much for the introduction, Dr. Linmar, and congratulations to the earlier speakers on excellent presentations. So today I'd like to present some of the lessons learned from planning the introduction of multiple micronutrient supplements in 4 countries in Asia and Sub-Saharan Africa. I'll start by providing background and objectives on the 4-country MMS project called Improving, and then present some lessons learned from planning for the MMS projects, ranging from the advocacy, the coordination, and the design of the projects, and then summarize some key takeaways. So let me start by introducing Improving, which stands for Improving Maternal and Pregnancy Outcomes Through Vital Interventions for Nutrition and Growth. This is a multi-year partnership between the Bill and Melinda Gates Foundation, UNICEF, and the governments of 4 countries, Bangladesh, Burkina Faso, Madagascar, and Tanzania, where the objective is to establish proof of concept for MMS introduction and then use those learnings to inform national scale-up and expand MMS introduction in additional countries. The first takeaway is that introducing MMS requires strong global and national planning and coordination. Country-level coordination and planning is essential for successful MMS introduction. So all the 4 countries have set up government-led technical advisory groups called TAGs, and these are strategically situated within the various government departments to take the lead on planning and coordination. For instance, in Bangladesh, the coordination is with the National Nutrition Services, whereas in Burkina Faso, the Directorate of Health takes the lead for MMS coordination. And in Tanzania, the responsibility sits with the Tanzania Food and Nutrition Council. The TAG has strong links with local research institutions that are responsible for developing the various protocols and conducting the analysis for the MMS demonstration projects. And these are also connected with other important initiatives that are ongoing in these 4 countries. For example, efforts to strengthen the nutrition information systems in Bangladesh and Burkina Faso, and health system strengthening initiatives such as universal healthcare across all 4 countries. And then accompanied by global technical support and partnerships, which help to buttress the work that is happening at country level. So within UNICEF, there's been strong internal collaboration with Supply Division, which has allowed us to set up long-term arrangements with 2 global MMS suppliers and initiate efforts to identify local producers of MMS. Externally, strong collaboration with partners such as Nutrition International has been instrumental in the cost-effectiveness analysis for making the advocacy case for MMS across the 4 countries. And then with Sight and Life, with whom we have collaborated to conduct the feasibility analyses of MMS production and procurement analysis and undertake the formative research to identify barriers for demand and gather feedback on women's preferences on MMS packaging and labeling. And then the Global MMS Technical Advisory Group, which has played an important role on the evidence base. So introducing MMS must be accompanied by a strong implementation plan. And in this slide, we show a generic implementation plan, which countries have then contextualized to their needs. And what we're showing here in beige are the steps of the plan that have already been completed. And the gray shapes are where countries are currently in the planning process. And then the white shapes are mainly related to the implementation phase, which is what remains. The second takeaway is that introducing MMS needs clear, context-specific advocacy. All 4 countries have adopted a common narrative, which is that MMS is a lever to improve maternal diets, anemia, low birth weight, and an opportunity to revitalize the provision of nutrition services in antenatal care. So poor maternal diets, anemia, low birth weight are widespread across all 4 countries. Anemia affects at least 1/3 of all pregnant women across the 4 countries, with ranges over 50% in Burkina Faso and Tanzania, and low birth weight ranging from 7% in Tanzania to 38% in Bangladesh. While data on women's diets and multiple micronutrient deficiencies is fragmented, countries have successfully used existing national and subnational data to make the case for MMS and to advocate for additional data collection. And so, for instance, in Tanzania, there are plans underway to undertake a baseline food intake survey to better understand the dietary patterns amongst pregnant women, and also a biomarker survey to measure multiple micronutrient deficiencies with support from USAID. And of course, countries have availed of the global evidence base and also the local evidence base to support MMS, as 3 of the 4 countries, Bangladesh, Burkina Faso, and Tanzania, have been sites for the clinical trials. All 4 countries have benefited from clear messaging that MMS is low cost, good value for money, and equitable to make the advocacy case. A 2-cents a tablet and $3.60 per pregnant woman covered using UNICEF costs. Conservative estimates by Nutrition International show that MMS can avert an additional 8 million disability-adjusted life years and 92,000 newborn deaths, with benefits outweighing costs. And furthermore, this analysis has been instrumental in securing government buy-in. The fact that MMS is a social equalizer, offering all women, including the poorest and the neediest in these countries, the same standard of care in pregnancy, has also resonated with policymakers. The second lesson learned is that MMS planning should be designed for scale-up. In all 4 countries, MMS is embedded in ongoing antenatal care programs. They are not designed as standalone research projects. Introducing MMS is part of a comprehensive effort to implement the WHO antenatal care guidelines, to revitalize antenatal care, and to deliver a core nutrition package of services, which includes MMS, maternal nutrition counseling, and weight gain monitoring. Each of the 4 countries has identified strategic entry points for introducing MMS. For instance, in Madagascar, MMS is embedded in a World Bank project which aims to strengthen the delivery of nutrition-specific interventions in the first 1,000 days. In all of these efforts, countries have created strong links between facilities and communities with the aim of bringing services closer to women and strengthening the demand side for MMS use. An illustration of this is in Burkina Faso, where the cadre of community health workers will promote and counsel women and families on early and continued antenatal care and MMS use. Another takeaway is that MMS needs to be part of a system strengthening approach and should be planned for as such. Currently, there are missed opportunities across all 4 countries where ANC4 coverage hovers around 50% and IFA coverage reaches only 1 in 5 women. This reflects the multiple bottlenecks that antenatal care platforms are currently facing to effectively deliver nutrition services to pregnant women. Now, countries have been opportunistic in introducing MMS in the same districts where there are ongoing efforts and resources available to strengthen health systems. In Bangladesh, it's being introduced in the same districts where the World Bank Pay for Performance initiative is implemented, along with government efforts to strengthen the competencies of healthcare providers to provide nutrition services. Countries have identified strategies to overcome these barriers, such as weak organization of antenatal care, the poor integration of nutritionist services, weak supply chains, financial barriers, along with gender and social norms. And a number of innovative strategies have been identified to address these. For instance, in Madagascar, one of the 2 selected districts will train community health workers to promote and distribute MMS to overcome barriers related to distance and access to MMS. And in Tanzania, they will test the use of the cell phone platform to send reminders and promotional messages to pregnant women. There's also agreement on the importance of having quality, uninterrupted MMS supplies. Countries have agreed to support a dual track, which includes agreement to import MMS for the project period and to also explore the feasibility of local production of MMS to enhance affordability, program ownership, and local economies and markets. With technical support provided from Site and Life, production, procurement, and regulatory analyses have been conducted in all 4 countries. And efforts are also ongoing to identify local MMS suppliers in Bangladesh to produce the recommended formulations. All 4 countries require MMS to align with national regulations and for MMS to be packaged in blisters and to explore options for improved labeling. UNICEF is working with suppliers to ensure that packaging is in local languages and to design and solicit feedback from women as part of the ongoing formative research. A final lesson from the planning phase is on the need to have clear and measurable definitions of success. Success under improving will be measured by achieving country coverage targets, but also measuring acceptance and adherence for MMS. Countries plan on using routine monitoring systems, the DHIS2, to collect coverage data. In Bangladesh, Burkina Faso, and Tanzania, this builds on existing investments to track stockouts and to strengthen nutrition information systems. And apart from this, in Bangladesh, they will use an individual tracking system to register women and children for services received, such as iron and folic acid, weight gain, and counseling. And success will also be measured by describing the policy shifts, the innovations, and the strategies which led to success and for which learning plans are being developed. So to summarize, MMS in these 4 countries represents an important laboratory of sorts to build operational experiences for MMS introduction and scale up. What we have learned from the planning phase thus far is that it requires multi-level planning and coordination, global level and country level. A clear understanding of the political and policy context to inform advocacy and MMS entry points. Embedding implementation research projects in ongoing antenatal care and system strengthening initiatives to inform scale up. And support for dual approaches with respect to MMS supply provision, which includes ensuring the immediate availability for implementation, as well as consideration for local production, regulations, and preferences. And then lessons learned from this planning phase are already informing MMS planning in other countries, in Ethiopia and the Philippines, for instance, and the development of the guidance document that my colleague Megan has already mentioned previously. And with that, I'd like to thank you for your attention and turn the floor over to Dr. Parul Christian, Professor at Johns Hopkins University. Thank you.
Thank you so much, Nita, and thank you to all the presenters who did a fabulous job in very clearly showing the evidence for the benefit of multiple micronutrients versus iron and folic acid, as well as demonstrating the cost effectiveness, interests of countries in moving towards programs, talking about how this can be achieved, how can implementation and rollout can happen, as well as thinking about the supply chain issue, etc. So there are wonderful questions and comments that have been made. I'll try to bin them into categories of different topics. Thank you, all the speakers, and I'll direct them to you sometimes, or feel free to pitch in when you think you have the answer to those questions. So let me kick it off by starting with the set of questions around the evidence for the benefit of multiple micronutrient supplements in pregnancy. A couple of questions around what evidence exists for an impact on maternal outcomes. If you want to take that, Emily, that'd be great. And I'll come back to that question again, which is in a different context, but if you can start us off with responding to that, that would be great. Thank you.
Yeah, so the main maternal health outcome that has been measured is anemia. And in the question of anemia, we see overall that MMS is as good as iron and folic acid as reducing the risk of maternal anemia. Broadly, I will say many studies did not measure many indicators of maternal health, which we see a lot in maternal and child health research. And I hope moving forward, we see more focus on mom's own health too. But overall, we see on average, it's the same. But I want to point out it will be different for every country. So if you have a high deficiency of vitamin B12, for example, or many vegan women in your population, then MMS may be better because it includes vitamin B12. And so the exact details of it will vary from place to place.
Great, thanks, Emily. And I just would also like to say that there is ongoing work happening to look at the impact of MMS interventions in the existing trials on the outcome of gestational weight gain, which was assessed in some of the trials, as well as a few studies have looked at the impact of MMS on other micronutrient status indicators, and the evidence there is that while the one RDA of 15 micronutrients has helped with correcting many deficiencies, it isn't as successful in eliminating those deficiencies. So there's more work to be done in that context. A related question, well, I'll wait for that. I'm going to go to the cost effectiveness presentation. And Reina, there are several questions for you on the costing and cost effectiveness analysis. One question was related to comparisons with fortification approaches and whether you have been able to do head-to-head comparison between cost per beneficiary for biofortification versus MMS, and especially for iodized salt, for example. Thank you.
Thank you. The short answer is no. We haven't done any head-to-head comparisons. I think maybe one of the challenges with fortification or interventions that are targeted at the whole population is that if they it may be difficult for those to meet the very high nutritional needs that are present in pregnancy. But certainly there's a potential for that to make a contribution. And so I think that's part of this question about the context and what interventions are already in place and what impact have those had, and then how does what does that mean for the relative benefits of the MMS?
Yeah, and if I can just ask a couple of more questions that are also directed to you, Reina. One of which is that what are the cost implications if you of starting MMS as a standalone versus phasing it out, phasing it in while IFA was being phased out? Would there be any cost benefit, not benefit in the impact sense, but would there be some savings if you're just rolling the MMS in with existing IFA platforms, if I'm understanding the question correctly?
For a practical question, and maybe the colleagues here who have been speaking to the country experiences could also talk about this, and if this has come up, I think I would expect that if the infrastructure is in place, then that's going to really facilitate switching that in. If you have the supply chains and people who are already trained on one tablet, I would expect that to be easier and more cost effective. But I think I don't know if the others on the in the panel would want to comment if that's come up in the country experiences.
Well, I would say that an existing strong ANC platform will definitely benefit the rollout of MMS in any context. And a related question was about training of delivery staff and primary healthcare personnel. It's the same response, that if those exist, then we are not talking about any additional cost for those individuals, except for some early cost of training them. I have a question. This is a programmatic question, and maybe Nita or Dr. Levin can answer this. The question was related to counseling in the context of MMS rollout, and focusing on both you talked about counseling women, but what about talking to their husbands? And so if you could address that. And I'm assuming other family members, such as the mother-in-law, etc., who would be influencers of what women do in these contexts.
Well, okay, I can go. So this is a very important question. Creating the enabling environment for women to be able to participate in their nutritional care as part of antenatal care. And for that, various barrier analysis have shown the influential role of family members, husbands, mother-in-laws, grandmothers, and other community members. And so the formative research that is being undertaken in all the 4 countries is going to help address what are the best demand strategies to make sure that we're not just messaging at women, but creating those kind of support structures around them that will allow them to feel supported in using MMS, in attending antenatal care. And so this is going to be a very, very important part of the overall project design. Over.
Great, thank you. So now moving on to questions that were about what about other population groups. So people were interested in the elderly population. Dr. Lewin, there was a question about whether you have any information on the micronutrient status among the elderly. Related to that, there was a question on adolescents, whether they could benefit from multiple micronutrients, as well as lactating mothers. And there was a specific question about whether we have any evidence for MMS improving breast milk composition and micronutrient levels, for example, and what should the timing of a lactation supplement could be? Should it continue beyond, of course, at the time of birth through the lactation period? Would it be required to begin early in pregnancy as well to improve breast milk quality as well as even infant status? So I think these are different. Maybe Dr. Lin, why don't you start with the elderly, and maybe Emily, you can take on, Nita, you can take on adolescents, and Emily can answer the breast milk and lactation supplementation question. Thank you.
Thank you, Thero. For the elderly, unfortunately, we didn't collect the data on micronutrient status of elderly population. In that micronutrient survey, we have assessed 7 target groups actually, including children under 5 years of age, 5 to 9 years children, adolescent girls, pregnant and lactating women, women of reproductive age, and including adult men between 15 to 49 years of age. Only the elderly population above 60 years and above, unfortunately, did not include in the survey. And so we don't have the data, but probably in next micronutrient survey in the country, because the elderly care unit also have requested us to assess the nutritional status of the elderly in our next nationwide survey. So this is that. And for lactating mothers, not to me, right? Do I need to?
Feel free to make
okay.
a comment if you wish.
Yeah, and another nutritional status of adolescent girls is, of course, we also found the anemia prevalence in the country. Adolescent girls is 29%, and also iron deficiency anemia in the adolescent girls also about. For adolescent girls, the iron deficiency was 15%, and also 15% was found. 15% of the adolescent girls, we found the iron deficiency, while 29% had anemia. For the lactating women, as I already mentioned in the presentation, we haven't provided the MMS in the lactating mothers, but we do have the thiamine supplementation for the lactating women up to 3 months after delivery, starting from the 9th month of pregnancy. Because why we choose that up to 3 months of pregnancy, because by the time we initiated the thiamine supplementation program, we have conducted some SAM national survey in the time and status of the pregnant and lactating women, and also SAM cause-specific under-5 mortality survey, we found that the highest prevalence of infant mortality due to thiamine deficiency was between the age of less than 3 months after birth. So, of course, one reason is we don't have the extra supplies or full of logistic support, so we have to prioritize the duration. So, thank you.
Thank you. Yeah. Maybe, Emily, do you want to address the evidence for the impact of MMS on breast milk composition?
Sure, I can say broadly the same principles apply to pregnancy and lactation, which is that there is an increased biological demand for micronutrients during this time. So even in the case you have a great diet, you need higher levels of many micronutrients during both periods of time. And in fact, in lactation, some of them are even higher. So in principle, I think it makes sense. And it's very clear, as Lindsay Allen has classified certain micronutrients very clearly. If you intake more, you eat more of them, this means there's more in the breast milk, so more transferred to the infant. And so that's very clear in a number of micronutrients, not all of them. Now, in terms of the clinical trials, there's less data about the actual impacts of continuing MMS during the lactation period. Parul, I know you've done a lot of work on this. You maybe have something to add about the trial evidence.
Yeah, so I think with regard to trial evidence, there is some effort to try and understand the impact of supplementation in lactation on breast milk composition a bit better. There are some trials which did collect breast milk at the time they did the studies and had extended the supplementation into the lactation period. So there's an opportunity to analyze those samples as well. There was one presentation in the Micronutrient Forum that addressed that. They just started analyzing a few nutrients in breast milk relative to micronutrient supplementation, and there'll be more information coming on that. Was one specific question about the use of the same Unimap or the composition that was presented in these talks. The iron content is higher than what is required for lactation. And there's a question about how should that be addressed? And I think that in the context of the WHO recommendation, especially in high burden situations, continuing taking iron in the postpartum period is actually recommended, and intermittent iron is also recommended. So I think that I would myself not have any concerns about continuing with the same formulation if that were an easier thing to do. I wanted to stick to this is the last set of questions on iron itself. And so one of the questions, and we've talked about this among in the TAG meetings, etc. But one issue that is raised is the WHO guidance currently recommends that in the context where anemia prevalence is over 40%, the MMS doesn't actually provide 60 milligrams of iron. And so what about all the countries that are currently using IFA with 60 milligrams of iron? What will the implications be for those countries if they were to switch to MMS? Can I ask one of the panelists to take this on?
Sure, I'm happy to speak to it, and anyone else can add. So I would say some of the clinical trials did in fact use a Unimap formulation with 60 milligrams of iron. Some of them used the formulation with 30 milligrams of iron. And so I think this is a good example where countries can make a decision about, given what they know about the burden of anemia and iron deficiency in their context, they can make a decision about a formulation that works best. Now, of course, the products that are available, and Nina maybe can also speak to this, many of them are the 30 milligrams of iron. So I think it's a balance between what you know about for your context about iron deficiency and about what products are available to use. That's my 2 cents. Maybe Nita has something to add.
Nita, do you have something to add to that?
Sorry, yes, I was just going to add, and this is an important point that's covered in the interim guidance that Megan presented. As we expected, a number of countries would be interested in having some answers to this question. And that is, in the formulation of the UNIMAP, we considered the fact that the 30 milligrams of iron would, along with the provision of other micronutrients, have certain iron absorbing properties that would allow for minimal side effects but better absorption. And so the multiple micronutrient supplement with 30 milligrams of iron does do that. And what we've seen from the trials is that 30 milligram iron containing UNIMAP actually worked just as well as the 60 milligrams of iron and folic acid as a standalone. And so the recommendation is for countries to really look at the etiologies of anemia that they have, because not all anemia is iron deficiency. And I know that there are some countries that are looking very closely at this and realizing that iron deficiency is a small part of that, and actually having the reduced amount of iron in the UNIMAP works quite well in their context. With respect to addressing the anemia needs of the iron needs of women in pregnancy. And I think that's where really taking a close look at your data is going to be helpful.
Nita, can you just stay on for a second? There's a quick question about tracking MMS in the context of DHS or similar national surveys. Is there any thinking on that issue as a country?
Did you mention DHS?
Yes.
DHS. Actually, it's a really good question, and I think that it would be very easy to swap it out. I mean, there are very few countries, as we know, that have large-scale implementation of MMS. In most countries, it is as part of implementation research, and that progressively this is something that needs to happen along with the introduction of MMS, the switching in and out into the DHIS2 and other surveys. So definitely something to, to look forward to.
Great. We are almost at time, and so I just want to take this opportunity to thank our fabulous speakers today for this exciting session and making such a convincing case for MMS being a beneficial intervention for pregnancy, for a really healthy and nutritious pregnancy experience. In 2020, we should be doing much better than trying to correct 1 or 2 deficiencies that women, even from an equity lens, deserve to have this intervention be available to them. So thank you, speakers, again. Thank you for the wonderful audience who asked some really great questions, and wish you all a great rest of the day and good time at the Micronutrient Forum, which continues to be exciting in this virtual environment. Thank you.